Now I'm going to pass it on to our speaker, Dr. John McCavick. But before I do, I'd like to give you a little bit of an introduction. So John is going to be speaking to us today about maximizing the health benefits of Canada's largest population health intervention, the expansion of urban trail networks. Sorry, I'm having trouble here with my mouse. Apologies, everybody. Okay, so Dr. McGavick is a professor in the Department of Pediatrics and Child Health at the University of Manitoba, and he's coming to us right now from there, as well as an investigator at the Children's Hospital Research Institute in Manitoba. His research focuses on the prevention and management of type 2 diabetes in youth, with a particular focus on physical activity. And studies in his lab range from studying the effectiveness and implementation of urban trails on cardiometabolic disease to clinical trials of novel behavioral interventions for adolescents living with diabetes, as well as the application of causal methods to uncover the role of the built environment and early life origins on adolescent cardiometabolic diseases. Dr. McGavick and his colleagues recently received a large CIHR grant to study how Canadian cities can best implement urban trails that are fair for all citizens and generate the greatest possible cardiovascular health benefits. And we are thrilled that the city of Mississauga has recently joined the team of participating cities across Canada for this project. And we're looking forward to hearing more about this exciting work. So please join me in welcoming Dr. John McGavick. I'll hand it over to you, John.
Thanks, Lorraine. Sad that I'm not in Mississauga today. I enjoyed my last trip there, but really happy to see some familiar faces or familiar names on the screen. Just going to share my screen, make sure you can see it. Thumbs up if you can.
Looks great, John.
Okay. My name is John McGavick. I'm a PhD scientist here at the Children's Hospital Research Institute of Manitoba and a co-founding member of DREAM, the Diabetes Research Envisioned and Accomplished in Manitoba research theme within our institute. I'm here on Treaty 1 land. This is the traditional lands of the Anishinaabe, Ojibwe, the Innu, Cree, and the homeland of the Red River Métis. We sit at the crossroads of truth and reconciliation here in Canada. I'm 3 kilometers away from one of the most iconic and historic gathering places for the Indigenous peoples in the Greater Prairies. I'm also 3 kilometers away from one of the last residential schools. The water that we get here is pumped in from a First Nation that they themselves only recently had clean water provided to their homes. The inequities that we see in our hospital, Children's Hospital, every day are evidence of the lasting impacts of colonization. And as a settler, I work closely with Indigenous community members, elders, and youth to overcome these inequities, which we acknowledge are grounded in the lasting impacts of colonization. So why should we study urban trails? Well, urban trails, which I'll define in a minute, are protected cycling paths that we're seeing grow in every city. In Europe and in Canada and in a lot of municipalities in westernized countries, all levels of government are investing hundreds of millions of dollars to expand these networks for 2 reasons. One, to create safe places for people to get to and from work, school, places they want to play. But also to get them out of cars, to mode shift them away from fossil fuels. And in an effort to combat climate change, they want to see more people riding bikes and riding them safely. There are various levels of the built environment that I'm sure you're aware of that we can study. The group led by Gillian Booth and her team within ICES have done a ton of work around walkability. And that might be one of the most popular, most common ways of studying the built environment as it pertains to health and physical activity. The other one is green space. Also, various cities and the canoe data set have mapped out different resources that are available within each community to support physical activity, recreation centers, municipal parks, municipal fitness centers, things like that. However, less attention has been given to urban trails. And so for the next 30 minutes or so, we're going to talk about the impact of urban trails on physical activity levels and health and their implementation characteristics that may define some of the variability in their effectiveness. So studying the built environment is a huge challenge for several epidemiological reasons. The first one is that most individuals self-select into the neighborhoods that they reside. So young, fit, healthy individuals who have the resources are able to choose areas with lots of green space, lots of urban trails. People who don't have the same kind of resources may not have the ability to choose to live there. And people who are not prioritizing physical activity in their life may not choose neighborhoods that support physical activity. Because people are self-selecting into neighborhoods, and a lot of times we're using the neighborhood as the exposure of interest, there's a lot of unmeasured confounding that clusters with that self-selection. And there's some measured confounding that we can establish in epidemiological studies, but are maybe not available within administrative health databases that we're going to talk about in a minute. The second aspect of the built environment that's challenging is it's a relatively static exposure. So we don't have changes in these variables over time, or we don't have large changes in most of these things like green space or walkability that facilitate natural experiments. And lastly, very few of the built environment exposures that we study at the epidemiological level rarely have population level or individual level uptake or use of them. And so it's sort of a blunt instrument. It's attractive to look at maps. It's nice to be able to cluster people based on their geographic exposure. However, when trying to understand a cause and effect for elements of the built environment and different health outcomes, it is a challenge. So urban trails offer some advantages that overcome some of those challenges associated with studying the built environment. First off, we do see large expansions of urban trails across multiple neighborhoods and multiple interventions occurring in many cities over time. So the urban trail network, this is Mississauga, for example, has expanded significantly in the last 10 to 15 years. With each extra track of trail, it represents a new natural experiment. The tracks of trails are fairly small in terms of geographic space, and so they can expand across hundreds of different neighborhoods. And in each of those neighborhoods, there are thousands of people. So as a natural experiment, it is very attractive because it does reach tens of thousands of people within a city in a small tract of land. And as these natural experiments come up, it offers us opportunities to study them. Second, there are different sources of data out there to look at how many people are using the trail. So one aspect of an effectiveness, or one way to define the effectiveness of a trail, would be to see how many people are actually using it on a daily basis. So depending on where you live or work or play, you may have seen one of these counters out there. I see them often in Ottawa. I haven't seen them as much in Mississauga, but these were developed by a company called Eco Counter out of Montreal. They have ones that are visible like this, so you can be proud of yourself and tap yourself on the back each time you ride your bike across one and see the number change. But they're also embedded in almost every trail that you walk or run on in most cities, and it allows city planners to get a sense of who's using it and when they're using it and what the traffic patterns look like. The second one, for any athletes in the on the call today or on the Zoom call, is Strava. So Strava is an app that you can download, and it integrates your GPS watch onto into this map. So for users, it'll give you a sense of like who's cycling where. For scientists, it'll give you a heat map here. So this heat map will tell us how many people are cycling, running, walking. I think they now have stand-up paddle boating, for example. And you can see the whiter the line, the more highly trafficked that space is. So in Mississauga, you can see where cyclists are going to and from different spaces. You can see that along the lakeshore, there's a ton of traffic. And along some of these corridors that are going, is this north-south? You can see much less traffic. So some trails are working really well, some are not. The advantage of this counter is that it captures every bike going across. The disadvantage is you don't know where those cyclists are going. The advantage of Strava is you can tell the start and the end point for individual level cyclists. However, it's a small segment, maybe 5 to 10% of total cyclists that are actually using Strava. integrating the two gives us a really nice sense of who's using the trails, how often, and for how long. And so this gives us a three-dimensional epidemiological space to study one of the fastest growing aspects of the built environment in most westernized cities. As you know, in terms of our empirical evidence, randomized controlled trials are the best level of evidence out there for guiding public policy or for guiding clinical practice guidelines. In the absence of a randomized controlled trial where it's not feasible, natural experiments provide us with that next level of high empirical evidence. And so the beauty of studying urban trails is that they're growing quickly, they're spanning across multiple neighborhoods, and so we can use causal methods to try to study them, and which I'll talk about later. And if we have access to large-scale health administrative data, we can create difference in difference designs. Or if we're looking at things like traffic or cycling counts or visits to a certain place, we can also use an interrupted time series analysis with or without a synthetic control, depending on the data that we have. And so for a difference in difference analysis, what's nice about urban trails, they will get implemented in certain neighborhoods who will get the intervention. Up here, they are not implemented in other neighborhoods. They don't get the intervention. And so we can track health outcomes over time before the implementation of a new trail, and then in multiple months, seasons, years after the trail to determine whether or not changes in health outcomes have occurred in conjunction with that implementation. Same thing here with an interrupted time series design. As long as we have pre-intervention data, we can estimate the slope for whatever outcome we're interested in prior to the intervention, prior to the implementation of a new urban trail, and then track it thereafter. And so I'll talk a little bit about how our lab's using these two designs and partnering with cities to try to understand the causal effects of adding new trails to health outcomes in the cities that receive them. So depending on how much cycling you do in your city or how much you pay attention to this, there are different ways that cities can try to create space for people to be active either on their bikes or to support pedestrian activity. This is probably the most common, where we have a shared use lane that just paints a bicycle on the lane. I have an 8-year-old. We like to cycle as a family. If an F-150 is trying to share the lane with me and my 8-year-old, this little paint isn't really protecting me. I don't feel very safe. I don't feel safe there with the painted dotted line either. And even if you make it green and try to slow down the traffic, it still does not create the kind of safety that we think is important for increasing the number of people who are going to ride their bikes. And so we focused all of our epidemiological studies to date and over the next 5 years on these two types of urban trails. So this is a separated bike lane, typically not used for pedestrians, often adjacent to a sidewalk, but protected from cycling traffic. And the second one would be a multi-use path, similar to your waterfront or lakeshore trail, where you can walk, ride, rollerblade, run, and it's shared between cyclists and other users. During the COVID pandemic, we saw a lot of this, open street concepts. They pop in and out of different cities at different times of year. They're challenging to study because of that variability and because of how different they are across different cities. So while this is becoming more common, we're not really studying it. And the rest of what I talk about today will be on these two types of trails. So we're going to try to answer the first 3 questions here. Does building new trails increase the level of physical activity in those cities? Do new trails reduce rates of cardiometabolic disease? And then we'll focus on implementation of trails and how that implementation can modify the effectiveness of the trail. So the theoretical framework that we're using to try to guide this work in my lab is that cities across Canada are building new trails, and they're doing it at a rapid pace. A lot of people in green have access to them in their neighborhoods and will use them. Some people in red will not get access to them in their neighborhood or may not feel safe using them, and so will potentially not benefit from the health benefits associated with new trails. Building them by themselves is not enough. People have to actually use them and use them for a sufficient amount of physical activity in terms of cycling or walking for them to accrue the health benefits associated with it. So first we need to see, are they actually increasing the amount of cycling or walking that people are doing in terms of their physical activity? Is that sustained over time? And then take a look at the health outcomes. So to what degree, or what's the level of evidence for how well these interventions increase the level of physical activity in neighborhoods that receive them? So there's some very good observational data across different countries using different designs. This one gives us, I guess, a bit of an example across 14 cities worldwide, looking at different aspects of the built environment that can support physical activity, and to what degree they can alter or to what degree are they associated with higher levels of physical activity. So having a park in your neighborhood, this should be minutes per week actually, is associated with about a 20-minute increase in daily physical activity for individuals who live within 500 meters of a park compared to individuals who live further away from a park. Individuals that have access to public transport, they are going to get more physical activity because they're walking to and from that public transport. Moving away from areas that are focused on cul-de-sacs and have more intersection density, making it easier to get to where you're going, is also associated with increased physical activity. And then your neighborhood density. So in terms of the number of people living there and the number of places that people can go, and the balance between schools, workplaces, and leisure type places are also associated with a higher amount of physical activity each week. And again, with each of these, there's an increased probability that an individual will meet their MVPA guidelines. What's interesting in all of these studies is very few people actually map out the amount of trails that are available for people to use. And so little information exists about to what degree do urban trails alter physical activity levels in neighborhoods. So the first natural experiment I want to describe is something that's unique to Winnipeg. I'm always super proud to show Winnipeg data. Because Winnipeg's so cold, we try to, rather than just hide indoors for 6 months of the year during the winter, we try to embrace it. And one of the ways that we've embraced it is to create this skating, walking, skiing trail. It's 10 kilometers long, and it follows the main river through town that goes north-south called the Red River. And part of it also goes on the other trail or the other river that goes east-west, the Assiniboine. And it comes together at this natural gathering place here. It's also a national park called the Forks. If you've ever been to Winnipeg, most people have probably recommended you go here. And so this trail provides a really nice natural experiment for us because they've plowed it for different types of physical activity. It's up for 2 months of the year. And it's up every year. So we decided to capitalize on that to see to what degree does this type of urban trail change physical activity levels and visits to this park over the course of time. So we call this Walking on Water. We were aiming for a BMJ Christmas edition special issue for those of you that are familiar with that. We didn't get it, unfortunately. But here's evidence that it was water or is water for some months of the year. And then for most months of the year, it is ice. And so what the local park here at the Forks has done is they have 2 Zambonis that will water the ice to make sure it's skatable. And then they have some snow removal gear that make sure you can skate on it. And then they've created opportunities not only for skating, but for walking, running, cycling. And then in some places, it's available to cross-country ski. And in terms of a natural experiment, what's nice is that we do have land-based trails as well that serve as a control. So when you come to this park, you can walk and run on trails 12 months of the year, but this natural experiment here only occurs for 2 months in January, February, and usually the first week of March. So what did our intervention look like? So we did 2 years, 2017, 2018, and 2018, 2019. This year was a polar vortex year. So it was a little bit chillier than usual. But the pre-control intervention time period is the fall, late fall, up to January 1st. So we had 20 days of data where we collected there, and average temperature the first year was -20. Pre-intervention, so the month of December -10. And then for 56 days in year 1 and 67 days in year 2, the intervention was open, the trail was open. And then after it was closed, after the ice started to melt, we had 31 days of post data in the first year, or sorry, 40 days of post data in the first year and 33 days in the second year. And you can see the temperature goes up to -4, -1, so it's not skatable. Unfortunately, I was out there, there's no pictures of me, but trust me, I was part of this data collection process. Unfortunately for the grad students in the team, they had to really bundle up for the polar vortex years and stand out there to ask people to fill out a survey. So we had 2 outcomes we were interested in. To what degree, or 3 outcomes, to what degree does the trail increase the amount of traffic to the park? The second one was, how much physical activity are people getting when they visit the park? And 3, what was their experience like while visiting the park? If you haven't been to Winnipeg in the winter and you come in February, this is outstanding. You'll absolutely love it. If you're from Ottawa, it's a million times better than what they do on the Rideau, which apparently couldn't open last year because of global warming. So strongly recommend you come out to Winnipeg. So what do we see? So we've embedded an eco counter at the park, just at the level of the entrance, to both the land-based trail and the river-based trail. This graph is the easiest one to visualize the change. So the first thing we're looking at here are this red line. So this is the temperature, the day-to-day temperature in the city. And you can see that in January, it's starting to fall. So down here, this is the polar vortex here. We've got days close to -40 and a fluctuation. And you can actually see how much the trail visits are impacted by the change in the temperature, right? So days where it drops down to -40, trail visits go down, temperature starts to rise again, people come back to the park. What you should be looking at next is the number of counts that we're seeing at the park. So here's the pre-intervention period. We're seeing 100 or so people each day visiting the park. Some days are busier than others. Weekends are obviously busier than weekdays. And then the day that the trail opened, January 6th, you can see counts increase dramatically and stay high throughout the intervention period, and then return back to normal as the spring starts. So these numbers here, close to 9,000 people in a day are coming to the park, is pretty close to what we're seeing in July. So just by clearing the snow and doing the Zamboni and putting some nice things out there, you can bring people out at levels that you would typically see in Canada today to come and use this trail. But are they, so you can see that trail counts are increasing about 4-fold during the intervention period, which park employees and anyone running any kind of business at the park really appreciate. And last year, when we had a really hard time getting the trail up and running, it affected a lot of businesses around because they rely heavily on this increased traffic as a result of that trail. But are people getting the amount of physical activity that we think they need to accrue health benefits? So you could argue that just having that there brings people out to drink hot chocolate, eat cinnamon buns, or have beer and wine at the facilities that are there. So we put pedometers on individuals as they went skating, walking or running on the park. We had about 500 people. Unfortunately, I didn't fill that out, but we had about 60% women. Average age was around 35 years of age. We're asking individuals to get about 10,000 steps in a day or 30 minutes in a day to meet physical activity guidelines to accrue a cardiovascular health benefit. Individuals are getting, on average, while they're out there, about 4,000 steps in about 30 minutes. And so just with one dose, with one visit of physical activity, they're getting very close to meeting their daily needs, their daily requirements for physical activity. So in terms of a strategy to shift populations to sort of top up their physical activity to meet the guidelines, we think this is a really attractive one. Most people embed this into their weekly plan for physical activity, and surveys of individuals said that the creation of this trail was something that they associated with their sustained rates of physical activity throughout the winter months. Now, that's a unique natural experiment in the wintertime. Other people have done different natural experiments across different cities. This was one done by Larry Frank in Vancouver. There's a trail that shoots right off of St. Paul's Hospital, goes right into Stanley Park. This corner here is right where the Sheridan is, if you've ever stayed downtown Vancouver. So they created this protected bike lane that took people from that area around Stanley Park up into the downtown area. Larry found that there was a threefold increase in the number of cycling trips, a 30% increase in MVPA. Similar work done in the Netherlands found mixed results. People tended to use this more often, but they didn't necessarily see an increase in their daily physical activity. And so we decided, based on these results and some mixed results of other natural experiments that we had read, that we would launch a systematic review and meta-analysis so that we could get a sense of what is the impact, and if we're designing other natural experiments, what kind of point estimates could we get from this, and the variability around that if we were designing one in the future. So summer students came into the lab. They screened 3,900 abstracts for a couple of months, and we ended up with 21 natural experiments. The inclusion criteria for this was that it had to be a controlled natural experiment with measures of physical activity, active commuting, or cycling counts in a pre-post design that actually had a control group. So it couldn't be an observational study. It had to be a natural experiment, and it had to have some kind of comparison group so that we could do a meta-analysis. The meta-analyses that had been done before this had all been more descriptive. They included a range of different study designs, and none of them had actually meta-analyzed the effects of the urban trail infrastructure on neighborhood levels of physical activity or active commuting. So we found of the 21 studies, there were 11 that had some measure of physical activity. Some of these had 2 point estimates based on the different methods used to assess physical activity. Overall, we saw that the pooled effect was an increase in physical activity overall, with quite a bit of variability within the study designs. A few of the studies saw a decrease in physical activity, while others saw huge increases. Importantly, some of this variability was captured by the methods used in terms of defining the intervention and the control group, which I'll talk about in a minute. But overall, we can see that at the population level, with a sample of around 10,000, there is an increase in physical activity levels for individuals living in neighborhoods that receive a new trail. Unfortunately, the majority of this work has been done in largely affluent neighborhoods with largely white participants in their studies. And none of these studies have assessed whether or not there's any changes in physical activity in youth. The only one that did looked at rates of active commuting using a national census. So overall, we can see that using natural experiments as the method, we have found that adding urban trails increases the number of people using them. Those who visit it increase their physical activity. And then for individuals living 500 meters to a kilometer of a new urban trail, they report higher levels of physical activity and higher levels of active commuting. However, there's a lot of heterogeneity there, and there is a need for better controlled, better designed natural experiments with better methods for capturing physical activity. So it looks like on a modest scale and using the experimental data that are available, if you build new trails, people will be more active, and people use them for different methods of walking or cycling. But does it reduce cardiovascular disease morbidity or mortality? So this is a paper we published last year. Here's the directed acyclic graph that attributes of the built environment are going to cluster with urban trails. But that we believe that the addition of urban trails will lead to increased levels of physical activity, and that will reduce the amount of cardiovascular disease, or reduce the rates of cardiovascular disease events or risk factors in the areas that receive an urban trail. So Winnipeg became Canada's largest natural experiment because we received in one fell swoop, $25 million to create new urban space to support protected cycling and walking. the plan was already developed by one of our partners, Winnipeg Trails. And so when the money came in, they were able to rapidly mobilize the funds and in 2 years create 4 long trails that were all multi-use paths that span multiple neighborhoods and connected people to work, school, and play. The 30 kilometers of new multi-use trails reached around 100 neighborhoods, and 40 to 50,000 residents received the intervention, and it was maintained for 12 months of the year. What does that look like? So here's an example of in 2004, there was sort of a dirt trail back here connecting this northern kind of farmland to this urban neighborhood. And by 2014, they had paved it. And then this now goes 4 or 5 kilometers down into one of the largest malls in the area. So it connects people to parks, their homes, and to residential area. Our study design capitalized on the fact that the city had embedded eco counters in all of these trails so we could track how many people were using it. We did surveys in partnership with a local not-for-profit that promotes and serves as an activist for new cycling infrastructure in the city. And then at the Manitoba Center for Health Policy, we were able to get seasonal level rates of cardiovascular disease events and cardiovascular disease risk factors, which were our 2 main outcomes of interest that we tracked from 2000 to 2010. And then we had a 2-year interruption, and then we tracked the composite outcomes for 10 years after that. What data linkage did we use? So most of you are familiar, I think, with the population health repositories in the different provinces. So we had individual level de-identified information for cardiovascular disease risk factors and events. We also had some social data that we could link in there. Every individual was linked to a neighborhood, and then we linked canoe data onto that to take a look at aspects of the built environment that were in their neighborhood that could serve as potential confounders. Neighborhood level demographics were used also to look at the diversity of the neighborhood. And then there's also, I think in most cities, there's an open data platform. So there we were able to take a look at household property value, to take a look at gentrification, and then some other city level factors that we used in our propensity score to just try to compare or to try to match neighborhoods that received an intervention with neighborhoods that didn't. So the main outcomes of interest were CVD related mortality, ischemic heart disease, stroke, and heart failure. That was our primary outcome. The term we use here is MACE. But the secondary outcome was a composite measure of hypertension, dyslipidemia, and diabetes, which we term CVD related risk factors. So we had control and intervention areas. We aligned these with the census in 2006 and 2016. There were around 400,000 people in the control areas, 40 to 48,000 people in the intervention areas. Average property value tripled over time. However, if you take a look at the household income in the intervention areas, it was slightly higher in the intervention compared to the control. So our index or indicator of wealth was a little bit higher. This is our CEFI. The other big difference between the two groups is that the control areas had larger numbers of visible minorities and larger numbers of individuals who immigrated in the last 10 years. And that stayed the same in 2016. And so the standardized differences there were large, but after propensity score matching, they were fairly well balanced. In terms of indicators for physical activity, walkability scores were a little bit lower in the intervention areas, and active commuting was also a little bit lower. So these were the suburbs that got them, and the urban downtown cores were the areas that didn't get them. So in terms of our causal inference, we were able to create propensity scores for the control group and the intervention group. And then we matched individuals based on these area level factors so that in our final analysis, propensity score matched regressions. We had fairly comparable groups to see whether or not there were differences over time. In terms of our other aspects of causal inference, we did see identical slopes for both the intervention and the control group before, so they were fairly well matched. The trails were not built in areas where there were high rates of cardiovascular disease, or in this case, gestational diabetes. So all individuals had sort of an equal opportunity to get into the intervention, and that there was no other interventions that were implemented around the same time, and that the intervention was not specifically designed to reduce cardiovascular disease outcomes or address a health-related need that we were studying as an outcome. So the eco counter data gave us a sense of, for each of the trails, how many people were using it. As you can expect, the seasonal shifts in cycling are massive. Very few people cycle in the winter. More people cycle in the summer. Importantly, though, if we take a look at 4,000 cyclists in a week as sort of the median here, this trail here was receiving around 6,000 cyclists, or 6,000 cyclists are using it in a week, compared to this trail here that's only getting around 3,000 a week. So just by building it, you're not going to get the same effectiveness. And so that's one of the things we do want to study later on. So what did we find? No impact of the urban trails on MACE. So incident rate ratios were not different. And we defined the intervention and control areas based on different buffers. So 4, 8, 12, no difference there. However, for CVD risk factors, we did have a signal there. We saw around an 8% reduction in the incident rate ratio for composite measure of CVD risk factors. And that was only seen at a 400-meter buffer. We didn't really see it at 8 or 12. However, when we take a look at the different trails, this signal is driven largely by the trail with the most traffic. So this was a significant 15% reduction in CVD risk factors in the trail that was getting around 4,000 cyclists per week. And we saw sort of a trend that the fewer people using a trail, the less likely you were going to see an effect on CVD risk factors. This, however, is just a pilot. We only had four trails to study, and it's only in one city. So our more recent CIHR grant is to expand that. So we're planning a pan-Canadian, collaborating with the team here in Mississauga, as well as teams in Edmonton, Sherbrooke, and Quebec City, to link geospatial map data, create natural experiments for all the new trails that were created between 2000 and 2016. We estimate there will be 1 million people who are exposed to these natural experiments. And then we'll have a lot of CVD events and risk factors to study to see whether or not we can replicate that. And we're going to use Strava data and eco-counter data to look at the dose effect, or the effectiveness of the trails on cycling. Now, to what degree does the implementation of the trails change this effectiveness? So whether we look at effectiveness as a health-related effectiveness or effectiveness on physical activity, in this case, I want to look at effectiveness as, does it bring people out, and do they use it for different types of cycling and walking? So what's important in implementation science is to try to understand some of this variability. So at the level of a new trail, there's going to be variability in how much physical activity, how much traffic it accrues. And then subsequently, there will be a lot of variability in the effectiveness on different health outcomes. So in terms of traffic, if we take a look at just Vancouver, the seawall, and I was here with my family a little while ago, they are recording 4,000 cyclists a day. When I was there, the counter was at 7,500, and it was like 6 o'clock at night. So there's your highest traffic trail. And then the Comox trail, I think that's down around Stanley Park, is getting 500. So you have a tenfold difference in effectiveness, if you will, in terms of trails built in different areas of one city. The same thing can be seen in different cities in the States. And I just showed you data from Winnipeg where we saw a twofold difference in cycling traffic. So what affects this? Here's our data in Winnipeg. The other aspect of effectiveness would also be, is it being used for active transportation? So of the 5 major multi-use trails that we have data for right now in Winnipeg, 3 of them create or are used as active transportation. So people are going to and from work. So you have this bimodal distribution here. And the other 2 trails are mostly used for evening after work, leisure type physical activity. They're getting far fewer cyclists per hour than the active transportation trails. And so we're trying to understand, why is that effectiveness different? Well, first off, the other thing that's incorporated for us into effectiveness is who's actually using it. So we linked the data that we used for that first paper with a First Nations identifier file. And we found that if you were First Nations and living in Winnipeg, you were 50% less likely to have any kind of infrastructure in your neighborhood back in 2006. And then after the implementation of these new urban trails, you were 40% less likely. So we have these persistent inequities in access to the trails that could explain some of this variability. And also when we do intercept surveys for both of the studies that we did, we found that First Nations and Métis people were 30 to 40% less likely to be seen on the trail, suggesting there's other barriers to using the trails that currently exist. And so part of our implementation strategy is also to try to uncover not only the variability that's happening up here, but also trying to understand why some of these trails are inaccessible to First Nation and Métis people. So the process of implementing a new trail is quite complex, multiple variable steps. Our group is trying to understand some of these factors, like who controls the plan and the funding, who's establishing priorities for the network, who's designing and actually implementing the network, who benefits from or receives the network, and then how are we tracking the network, the cycling network over time to see how well it's working. I can't get into this. I'm sure you're going to get 2 or 3 talks on this the rest of the year, but the implementation frameworks that we're going to use are a traditional one to look at outcomes, such as reach, maintenance, adoption, implementation, and then effectiveness for us is counts. And then the CFIR framework will give us some understanding of why there's differences in these implementation outcomes. So looking at different factors within the city, within the municipal government, within neighborhoods to try to understand what's driving some of these differences in implementation. So our CHR grant involves all of these cities here. We have 8 cities who are partnering with us. The municipal governments are giving us access to some of their data, and their urban transportation or urban planning teams are involved in our grants as knowledge users. And we're going to collect 5 different types of data. So we're going to have trail counts for all the trails in every city. We're going to do geospatial mapping to see who's getting access to these trails. We're also going to do surveillance of the trails to see who's using them. The beauty of this study is that we do have active transportation plans for every city, so we can see who planned it out and to what degree did they follow the plan that they had originally set out. And then we'll do focus groups with different groups, people not using the trail, people using the trail, people planning and implementing the trail, to try to understand, why are we seeing what we're seeing in terms of variation in effectiveness and differences in different implementation outcomes. So preliminary data hot off the press from this summer. High impact trails are obviously, you're seeing more traffic in neighborhoods that have a higher population. Importantly though, you're seeing higher traffic on trails and more of an AT profile in neighborhoods that have more persons of color and newcomers. So the more diverse the area, the more likely that you're going to see more people in there. However, there's also this inequity here in Winnipeg that these trails are mostly being built in higher income neighborhoods. In terms of surveys, we've done 500 surveys this summer. We found that high impact trails are more likely to meet the needs of trail users than people using low impact trails. People on high impact trails also feel like there's better connectivity on their trail compared to people who are being intercepted on a low impact trail. And most importantly, there's a big difference in motor safety. So people using a high impact trail perceive the safety of that trail to be much better than people using low impact trails. So we have 4 or 5 years partnering with each of these cities to do intercept surveys and look at documents over time to see to what degree this holds true in different areas. And we're just pulling together all these active transportation plans to see what we can find. First pass at a lot of these, we got a lot of white people making a lot of decisions for a lot of people of color. So in summary, if you build new trails, people use it, they will get more active. Preliminary data in our city suggests that it may reduce cardiovascular disease if it elicits enough traffic. However, there are significant inequities in access and use, and these may be related to implementation. And so really want to thank a lot of people here, including some of the people on this call, and look forward to taking any questions that you have.
Great. John, thank you so much for an excellent presentation. I'm just going to turn my video. Oh, it tells me I'm not allowed. Can you let me turn on my video, Lydia, please?
Yep, I will. Sorry about that.
All right. And maybe let others too, if they want to ask a question. I think it'd be nice to see people's faces. Can I? Okay, great. Jonathan, that was really a great summary and presentation of the impressive amount of work that you've done in this area, and really important. And we're really excited to also be part of this work in Mississauga. I'm going to open it up for any questions that people might have. Just raise your hand or come off mute or put your question in the chat. Just going to give people a minute. And as we're waiting for people to think about questions, maybe I'll ask you one. So you answered a lot of my questions as I was writing them down. You know, you seem to have thought of everything, John. But maybe you could expand on a couple of things that I thought was particularly interesting from your work. And maybe I'll start with the first question. You did mention that you are planning on doing focus groups to understand, you know, to hear from people who aren't using the trails, and what are sort of those barriers to using trails and facilitators, and what would get people out there, right? So has there been either any work already getting some of that data from people who aren't using trails and try to understand what may be some barriers, either from Winnipeg or from other places?
Mm-hmm. Well, we're super grateful. We partnered with, I see Matt Adams is on the call, and we had a summer student, Rosa, who was collecting some data. And so the Mississauga information will be different than the Winnipeg information. But the Winnipeg data that we have is largely from Indigenous women. And Indigenous women not using the trails would say parks, rivers, water are sacred and ceremonial to us, but we don't feel safe. We feel racialized, right? Mm-hmm. So one woman had a powerful, like, you know, it just reminds me that I'm invisible, right? Mm-hmm. That I'm nothing. Like, it was something just horrible. Another member of our family guide group said, you know, it's easier for people here to get murdered than it is to get physically active, right? To live a healthy lifestyle. And mm-hmm. So safety and a sense of belonging, or sense of disconnection from their community, is huge. Socioeconomic factors, like not having access to a bike, you know, bikes being a privilege. Like, most of us have a car, right? And we can choose, or we're choosing a bike over a car, right? Whereas in a lot of these neighborhoods, people are like if I don't have a bike, I'm taking the bus or I'm walking, but I don't have this luxury that you have. And the other one was that in the neighborhoods where we partner with First Nation Métis people, they want to be connected to places where they can gather and meet with one another. And what we're building are thoroughfares through neighborhoods for, like, you know, the white upper income individuals to ride through their neighborhood to get to work, kind of thing. Mm-hmm. So those are huge barriers. But as we were surveying people on one of our biggest corridors, we were watching, you know, just dozens, you know, every 20 minutes, dozens of white guys. So I'm in this category here, right? White guys riding to work, and we're intercepting just middle-aged white guys over and over and over again. And right beside us was this brand new transit station. So it's a rapid transit, and everyone getting off there was female of color. And so, you know, the next summer, I want us to be there to say, we're not only going to ask people who are using the trail what they think, like, as you're getting off the bus, we want to know, like, why are you not using a bike? Like, what's the difference here? The bike trail and the rapid transit go in similar directions into the same spot. So I think there's something there we just haven't captured. And I know in Mississauga it'll be the same thing. but particularly for the South Asian community, right?
Yeah, I think you're raising a good point, is that, cycling is seen as something that is like an activity of certain sociodemographic group, and doesn't feel like something that everybody can do, particularly for active transit, maybe due to historical reasons, because of lack of safety of bike transit areas, etc. The other point that you made, it's escaping me now. Yes, oh yes. So some of these multi-use trails are also being used for walking, by either for active transit or for leisure. And are you able to do any sort of analysis of how many people are using them for walking? I know you talked a lot about cycling.
We haven't yet. Some of the eco-counter data do provide pedestrian and cycling data, so we want to get to that. And the neighborhood that I grew up in is largely mixed. And so large numbers of new Filipino immigrants and large families from the Punjabi region of India. And when I go to my neighborhood where my parents are, those trails are being used for family walks after supper. Quite a bit.
Yeah.
And so we need to capture that, right? Because we're not capturing. People aren't using them necessarily for cycling. So there are some different uses for different reasons. And so I think we need to expand in the next year to try to understand what those differences are.
Thank you. That's great. Okay, so we have a comment in the chat and we have connections. We have a comment in the chat and we have a hand up. I'm going to just read the comment in the chat from Adria Sehoven. I would suggest connecting with the bike trail system in Burlington, Ontario. It's a very interesting place. There's a big mix of walking and biking. Okay, thanks, Adria. I don't know if you have connections there in Burlington, but you can let us know. It'd be great to speak to somebody there. Nick?
I don't know, can you see me? Sorry, I'm on my phone.
We can see you.
Perfect. Thanks you so much for the talk, John. Really, really interesting. I was just curious, so myself, like I'm a avid Strava user, and I was curious sort of what type of data do you pull from that platform, and is it sort of publicly available, or do you have to apply through Strava to get access to that data?
You have to apply for it. You can't get segments. So if you want to know segment specific data, they won't give you that, but they will give you the total counts in a certain geographic area. And they will give you the breakdown because Strava is collecting demographic data, and they are moving towards trying to support anti-racism type work. And so they have asked us to identify as Strava users. You do have to apply for it, and they're moving to a different system in the new year where we'll have to apply, and they're limiting the number of people that will have access to it. And it does have to have, they have a big social justice platform. So you can't just use it for any type of activity or any type of research. They do want to see some justice or some like equity projects built into that. And you can get it in every city in Canada, but you need a partner in that city. So for us, we would have the active transportation team members apply for it. And we're actually working with Strava to say, like, we have this grant, we're doing this work. All these members of our team are there. Can you just give us access to it? Cool stuff. And there's good work by Jamie Fisher, a Métis scholar in our team, showing that it's only, let's say, 5 to 10% of the eco-counter data, but whatever trends you see in Strava map very closely onto eco-counter. So if you're getting counts on a trail, you know, if it's higher relative to another trail in the city, that relative difference would be the same if it was captured using an eco-counter.
Got it. That was really, really interesting. Thanks so much.
Yeah, no problem. Keep riding or
Jillian.
running, whatever it is.
Jillian.
Hi, great talk as always, John. So just a quick question, just remind me for the focus group, so you're also going to be speaking to the policymakers and decision makers, thinking about, you know, what would change their decisions on where to invest. Because as you pointed out in Winnipeg, there were more trails being built in higher income neighborhoods. And I'm always thinking, you know, if you could build another bicycle path in the annex, you will demonstrate in a short time that it will be used. But, there's a lot of neighborhoods that need it more and for health. And I'm just thinking about also along that line, how can we incorporate the community voice in terms of, as you said, these decisions, like people want to be able to go somewhere, and then how do you incorporate that rather than have these plans that are built 5 years in advance without, from kind of a top-down approach. Sorry, it's a lot to answer in a quick period of time, so sorry. In a short
no,
period.
that's okay. So yes, so the focus groups and key informant interviews. So some people just know so much about what's happening. We were renting bikes in Port Credit to go do field data in Mississauga. And the guy renting us a bike was like, oh, I was part of this committee that Hazel, right? Created, the mayor of Mississauga was.
Hazel McCallum, yeah.
Yes. Where we represented each of the different communities and said, these are the priorities for where we want to go. So that person's key informant, right? And he could tell you, you know what, we made this decision, or we asked for this and we didn't get it, and we think this is why. The other thing we've noticed in the city, looking at documents, for whatever reason, like Winnipeg is committed to reconciliation. We have an Indigenous Accord. We have an Indigenous working group. One of them's an active planner, like she's on our team, or she's a city planner and architect. She helped rename some of the trails, but when they did the city master plan, there's no Indigenous people there. And so trying to understand, like, where does that disconnect happen? How does that silo of we're doing this here and we're really committed to it, but then when we're actually spending money, there's no connection there. So focus groups with individuals within the city who can try to help us understand like where these disconnects are happening. The one thing I've heard from the city on the inside is they don't want to screw up and do it the wrong way. So I think they're just waiting until someone finds the best way to help them to do it so they don't look bad.
Thank you, John. I see we're just at 1 o'clock. There is a question in the chat, and if you can answer it maybe in 30 seconds. Do you have any information on how different type of disabilities influence the experience of using urban trails and possible modifications that could be considered to improve usability? Maybe a brief answer. I know it may not be easy to answer quickly, but just before we head out.
That has been the priority for cities for the last 10 years, is all ages and abilities. And so they are moving it. However, bar none, it's the surfaces and it's the transitions that affect ability. So if you're older, if you're in a wheelchair, if you have any kind of mobility issue, the trail itself might be okay. As you transition, that's where people are really struggling or like getting access to it from wherever they work, live, or play.
Yeah. John, thank you. I know that was a short answer. I'm sure there's a lot more you could say, but I do realize we're at 1 minute over time. So I want to ask everybody to join me in thanking John McGavick for a really excellent presentation and sharing with us just some great work. Congratulations. We're looking forward to continuing to do this work with you in Mississauga. And so please ensure that you complete today's evaluation for this session, and the link has been added to the chat pod. Just as a reminder, our next University of Toronto Network for Healthy Populations BBDC joint research in progress rounds will be on October 21st, 2024, and we'll have 2 of our network's grad students presenting their research, and we'll send out the flyer soon. So once again, we hope to see you there, and thank you again, John, and thanks everyone for attending. Have a wonderful afternoon.
Thank you.